From here, I'll actually was intending to talk about for 10 minutes, but if with interest of time, I would really cut it short to 5 minutes. And I would also run through the facts that why we arrived to the fact that probably this could be the next thing in TNBC to understand whether immunotherapy is needed or not. So if we can share the slides, please. So first of all, I'll just like to take you through to the first 10 patients that we have done on nanostring to understand Prosigna assay. And these were the first patients. So very interestingly, of course, all the criteria is met, and this were the initial validation observation. The next slide, I'll take you through what was the observation. Can you move the slide, please? Yeah. So very interestingly, we luminal A is less aggressive than luminal B cancer types. So if we see this particular initial cohort, I would like to also say that PAM50 Prosigna assay is a FDA approved assay, which is a only decentralized assay that is available across the world, and anybody can take that particular assay and run it because it is already FDA approved. It is having 17% of Asian population. How much Indian in that, we really don't know. But we as a company, we have already completed 100 commercial samples over there, which is in Indian populations. So that was the first source of point to understand. So nanostring, the machine itself, it gives the molecular subtyping of any breast sample we run. So whether it's ERPR positive, HER2 negative, whether it is TNBC, we do have an understanding that whether or not my patient is having what molecular subtype. So very interestingly, the first 10 or 11 cases that we have seen is that whichever has come ROR as a low score, meaning that the DFS for the 10 years, the risk of recurrence is low in those patients mostly dominated, 66%, 68% precisely were luminal A. And rest of them has come to be luminal B. So this was the first observation that we got, and every sample that we run, we had it scored behind for this particular patients. Next slide, please. So basically the 18 gene tumor inflammation signature, as we call it, TIS. So this is a combination of the 18 gene that has been looked into and whether or not. So it is basically on the proliferation that is happening, the score is happening on the cell membrane level. We check that and we understand whether or not my TNBC patient would be responding to any kind of immunotherapy or not. So this idea has come in July 26, meaning July 26 date, 2021, when Keytruda was approved, that for any TNBC patient, whether it's a recurrent or whether it is a METS TNBC, Keytruda can be given if it is PD-L1 positive. Now the question that arises at that particular point of time is that whether PD-L1 is enough, a marker to understand that my patient would be doing really good, the DFS would be good, good meaning like at least the quality of life is good. There was no such definite answer. So to find that, so next. So I'll just take you through only one case. This was a very interesting case, one of those 11 cases, other than those 11 cases, sorry. So this was all triple, I mean, ER positive, PR positive, HER2 positive, and everything. So where does particularly my TNBC role, can you move to the next slide, please, come into the picture, is that it says the nanostring, the PAM50 assay is extended assay to BRC360, which says that anything, if my TIS is above 7 for any breast cancer tissue type, it should have a good response to the immunotherapy. Now, when we started or thought of launching commercially that whether or not we should be running it for the TNBC patient, the question that we got that, so we don't need to run PD-L1 that you want to say. We don't have that data now, right now. So post that, after understanding through this entire India survey, we went back to Dr. Gupta, that is Dr. Sudeep Gupta, and we conceptualized a study which is yet in a conceptualization phase, and we are yet to write a protocol on that. It is in the drafting phase, which says, go to the last slide. I'll just leave you with the observations, conceptualization. Last. Yeah. So basically, the idea of that particular study would be observe the DFS of the TNBC patients who are PD-L1 positive population treated with Keytruda. In the back end, those particular tissues would be taken and the TIS score would be run in nanostring. We would be having that without understanding whether that particular person is, however they are progressing, how is their DFS, whatever their clinical, whatever their quality of life. The third part of it would be post 3 years, there would be a concordance between PD-L1 and TIS. The basic reason is there could be multiple possibility of this. The possibility could be my patient is PD-L1 positive, TNBC, either it is recurrent or it's a METS and I have put it on immunotherapy. I really don't know how is the DFS. Possibly there could be the PD-L1 positive could be TIS negative. The PD-L1 negative could be TIS positive, or both of them positive could be positive. So we really need to check the answer. Just go to the next slide. So we really need to check the answer whether PD-L1 is enough, as it says in 2021, that whether I should be going through TNBC, or as if the data emerging for last 3-4 years, that TIS is the one marker for my breast cancer TNBC patients. We really need to look into a concordance study which will have the enough data. Now we always get really happy with the fact that we have Western data. Good, great enough. To get into the guidelines, to avoid medical legal issues and all that, that is good. But Indians are Indians, even they are the subset of the Asian population. So we would be running that into the Indian population, we would be looking into that, and we would be particularly understand that whether or not we can do TIS and TNBC at the same time when the patient is failing on the chemotherapy, and whether or not I should be going ahead with the chemotherapy. So that's the entire idea. I have really cut it short. There were a lot of case studies which shows that the TIS is making a lot of difference. So in casually in between when the different discussions are going on, I'll pitch in and I'll put my thoughts into. Thank you.
Thank you, Tanya. I just have a question.
Yes.
You said that it was mainly to see the correlation between PD-L1 and TIS.
Correct.
But then in the end you mentioned about chemo resistance. But
correct.
This TIS that you are actually alluding to is
correct.
not the same as the senescent cells which allude to
chemo
chemo resistance.
No.
I don't think this would...
I did not mention that chemo resistant. So what I try to mention is when chemotherapy is possibly failing, and if we wish to move to immunotherapy, whether or not PD-L1 is enough for my patient or TIS is enough. So that is what the nanostring particularly measured is.
The thing is that immunotherapy in the metastatic setting is actually approved first line. So, we would be wanting to know about TIS at that time, not after failure of chemo in the metastatic setting. So
correct. So this is absolutely the conceptualization idea. This is the first thought that came in when we spoke to Dr. Gupta, that whether we would be running it in the back end, because we wanted to upfront what was our idea was, we wanted to do in the same patient, we wanted to run PD-L1 and TIS at the first setting itself, and want to see whether TIS is the one and how my patient is progressing. So, but then again, we cannot do it in real world data. We have to do it in a prospective trial to run it. So whether we go in that model or whether we go in a back calculation model, that is yet to be decided. That's why we are still drafting that particular objective and how do we go about the trial.
Okay. Okay. So I think with that, we move to the next talk, and that is the gene assay, new tool for treatment decision in early breast cancer. So Dr. Devrat Arya, yeah, so he's online.
Hi, good evening. Am I audible?
Yes, yes, you are audible.
I'm really sorry. I'm having a lot of power issues at my end. So I lost the meeting in between. So I hope it's my turn to talk.
It's your session. You can please go ahead.
Yeah. So first of all, thank you very much for this opportunity to talk here in brief on the OncoPrecise risk predictor, the ProSigna test. Next slide, please. So we know that the incidence of breast cancer is increasing in our country. The numbers, especially in the urban areas, are going up. We see anywhere between 1.7 to 1.8 lakh new cancer cases being diagnosed every year. I think while we've struggled with more advanced stage 3, stage 4 diseases, what we are clearly seeing is that an increasing number of women, even in India, are diagnosed with early breast cancers. So according to one estimates, and one could argue for or against these statistics, but according to one estimate, as many as 65,000 new early stage HER2, ERPR positive, HER2 negative breast cancers may be diagnosed every year. Now, obviously, we are living in a very strange era in medical oncology, in breast cancer in particular, where at one end we are trying to escalate treatment for the more advanced disease. At the other end, we are also trying to de-escalate treatment for the early biologically favorable disease. And early ER and ER positive breast cancers falls in the latter category. And there is data to suggest that a significant number of these women actually do very well without having the need for any adjuvant chemotherapy. And there are some estimates to suggest that only about 15 in 100 end up needing chemotherapy to prevent a recurrence. Next slide, please. So when you look at the NCCN guidelines and when you look at disease, particularly any menopausal status, but particularly in pre-menopausal status, and I encounter this in my practice quite often. We have women who have been diagnosed with a T1 or T2 N0 disease, and they are pre-menopausal, and quite a number of times they can't afford a expensive test like an Oncotype DX. When you look at the guidelines, when you look at if the Oncotype DX is not done, the recommendation is that you have to offer the patient adjuvant chemotherapy along with endocrine therapy, and that's the category 1 recommendation as per the NCCN guidelines. Obviously, one could choose adjuvant endocrine therapy along with ovarian function suppression alone, but as per the guideline, the stronger recommendation is actually to do chemotherapy irrespective of the size of the tumor, particularly in a pre-menopausal setting. Obviously, in a post-menopausal setting, the decision may be guided by the size of the tumor, the grade of the tumor, the Ki67, the age, the frailty, the comorbidities, but all of these factors may not be that important in a younger population in a pre-menopausal setting. Next slide, please. So as I said, this is what the guidelines says, that if you haven't done, the patient cannot afford an expensive gene expression profiling, and unfortunately, chemotherapy is the way to go for majority of these patients. Next slide, please. So this is where the challenge comes in. How do you identify those 15 women out of those 100 who have a higher risk of recurrence and therefore would deserve chemotherapy, and let the other 85 with a lower risk of recurrence go without enduring any short-term or possible long-term side effects of adjuvant chemotherapy. Next slide, please. So we looked at our own data a couple of years back, and we actually were able to identify 90 women with an early breast cancer who were able to undertake an Oncotype DX, and we analyzed that data retrospectively. So what we did was we collected the clinicopathological characteristics. We looked at the Nottingham Prognostic Index. We looked at the recommendations of PREDICT, which is in version 2. And we also looked at their age, their histopathology, and between us 4 medical oncologists, we actually sat down and said, okay, we look at the clinical pathological characteristics, the PREDICT score, the patient age, the actual histopathology report, and then we'll decide what we want to do, whether we would have, in the absence of a gene expression profiling, offered chemotherapy or offered hormone therapy alone. Next slide, please. And what we realized was that in as many as 52% women, while we recommended chemotherapy for these women, in 52% cases, the Oncotype DX score came back as low. And this is our data. I know the data correspondingly may be different across different centers and across different stage groups and age groups as well. But at least what we realized was that in about half of these women, where we thought chemo was needed, chemo wasn't needed. In only about 5 to 7% women, where we thought that chemo was not needed, Oncotype DX actually came back as high and suggested that adjuvant chemotherapy should be done. Next slide, please. I think this clearly highlights the fact that gene expression profiling, and this is only Oncotype DX, and I'm sure that we plan to look at our data again with some of the other tests that have come in since then. What clearly seems to be coming out is that in a significant number of patients, nearly half of our patients, at least as per our data, the decision for adjuvant treatment can be radically changed if you undertake a gene expression profiling. And given the context, given that our women are younger, sometimes they have a bigger primary, and significant number of women may actually have a symptomatic detection, not a screening-based detection. I think compared to the Western population, gene expression profiling may, and I underline the fact, may actually carry a lot more value, provided we are able to come up with a more cost-effective way of testing. Next slide. So, clearly prognostic tests assess the chance of cancer recurrence, help in identifying the people who need escalation of care, need chemotherapy. I think we've all had our experiences with the international tests, Oncotype DX and Mammoth Print, which have been developed in the US and Europe and have been widely adopted. But increasingly, we have 2 other tests. We have the Procina assay, the Oncoprecise risk predictor, is also a US FDA approved. And clearly, with the use of these tests, you identify those patients who do not need chemotherapy, prevent short-term, prevent long-term side effects, improve their quality of life. Next slide, please. So, what is the Procina test? I mean, clearly, it's a RNA-based test on a PAM50 platform and nanostring-based technology. So, basically, on fresh, on paraffin-embedded tissue, pathologists would look at these slides and blocks and confirm the presence of the tumor. And then following this, there is the RNA analysis by the encounter analysis system. And then the score comes in. Next slide, please. I think what's important is that along with the RNA analysis, the PAM50 gene expression data, it also looks at some of the clinical parameters like the tumor size. It's a binary division between a tumor less than 2 centimeters versus a tumor more than 2 centimeters. Also at the proliferation score, and this is what helps determine the ROR score, which is the risk of recurrence score. So this is a test that uses both tumor biology and the anatomy for calculating risk of recurrence and classification. And particularly, this is also approved for node positive setting in the N1, 1 to 3 nodes positive. So one can actually come up with a score which can then be classified based on the cutoff criteria, and then that score can be used for our decision making for the need of adjuvant chemotherapy. Next slide, please. So this is one of the many papers This was published in the Breast Cancer Research. So they looked at the data and they said, let's look at different scores, different classifications based on the PAN50. So this is the Kaplan-Meier plot of breast cancer specific survival and distant disease-free survival according to PAN50 subtypes. So this is classification based on luminal A, B, HER2 enriched and basal line. And clearly, when you see the curves and you can clearly see that luminal A stays on top. Luminal B is actually slightly, in fact, significantly worse compared to luminal A. But there's a clear-cut separation of all these three subtypes when you look at breast cancer specific survival and distant recurrence-free survival. Next slide, please. And when you look at the ROR classification into the low, intermediate, and high, the blue curve being the low risk. You look at the outcomes, breast cancer specific survival, the low scores, the patients with the low score are doing very well, and about 15 years from surgery, the breast cancer specific survival is upwards of 90%. For the intermediate risk, also the breast cancer specific survival is about 85%, and compared to the high risk category where the breast cancer specific survival at 15 years is about 70%. And when you look at distant recurrence free survival, you have a similar pattern. The low and the intermediate risk group doing quite well. Distant recurrence free survival close to about 85 to 95% in the low, the intermediate and low risk respectively. And when you look at the high risk, the distant recurrence free survival sitting at around 80% at 8 years. Next slide, please. And so a lot of times in my clinical practice where you don't have the resources to do a gene expression profiling, I've ended up using Predict or Adjuvant Online as it was known earlier. And quite often, it becomes a habit just to do the scoring based on Predict, and sometimes you feel that's good enough. But clearly there's data to suggest that compared to doing calculation on the Predict platform, and again this is a platform based on data from the UK, and it's a UK NHS platform, there's a significant improvement while we do a scoring based on Procina, and it's actually even better than the IHC4 that looks at the ER, PR, HER2 and P67. Next slide, please. So based on this data, in fact many more data, OncoPrecise is approved by and recommended by most international guidelines, including NCCN, ASCO, ESMO, NICE, etc. Next slide. And amongst the various expression profiling platforms, clearly Procina has been recommended, strongly recommended as the preferred gene expression profiling assay. Next slide, please. And I think clearly what we know is that while Oncotype DX for us and to some extent EndoPredict and MammaPrint have been the tests that we use more often, I think while there were 15% Asian population in the Procina studies, there were hardly any Indian patients that were evaluated in the studies with Oncotype DX or MammaPrint. Next slide, please. So clearly Procina is an option, and I think where it scores is that it's relatively cheaper, and for a lot of my patients who are not able to afford Oncotype DX or EndoPredict, this test actually offers them an opportunity to still have a gene expression profiling and base their adjuvant decision making based on the results. Next slide, please. So this is what the report looks like. This is a dummy report. For a node negative population, there are three subcategorization: 0 to 40, 41 to 60, and 61 to 100, being low, intermediate, and high risk. Clearly, for a low risk, there's no need for adjuvant chemotherapy, and the curves being very close for even intermediate risk, I think it's fair to not offer chemotherapy even for the intermediate risk, but clearly for the high risk, adjuvant chemotherapy is indicated. The classification is more binary for a node positive setting, and this is 1 to 3 nodes, where 0 to 40 is low risk and 41 to 100 is considered high risk. And women with a high risk score, it's been calculated that there's a greater than 20% risk of distant recurrence and therefore should be offered adjuvant chemotherapy. Next slide, please. So I conclude by saying that a significant number of Indian women are also presenting with a ER/PR positive early breast cancer, and despite modest benefits, there are settings where a clinician being unable to pick up a possible high-risk patient would end up offering chemotherapy to a significant number of these women. And while there is data to suggest that only about 15 to 20% women actually warrant adjuvant chemotherapy, and gene expression profiling is increasingly being used to determine the risk of recurrence and therefore aid in adjuvant decision making. And apart from the other tests, OncoPrecise Risk Predictor is one of the tests which is now easily available and is much more cost effective, at least cheaper, which has helped improve the classification of patients with breast cancer into prognostic groups and identifying the high risk of patients with high risk of recurrence and therefore warranting chemotherapy, and helping de-escalate treatment for those patients where the risk of recurrence is low and therefore the short and long-term side effects of chemotherapy can be avoided. So with that, I thank you very much for your patient hearing. Thank you. Back to the organizers.
Thank you, Dr. Devrat Arya, for that nice presentation on the test itself. Only thing, of course, is that it is mainly meant for post-menopausal women and not for the pre-menopausal. And of course, we all know that as far as Oncotype DX is also concerned, the data is a little sparse in the pre-menopausal. So if you are in doubt and just don't use the Oncotype DX alone in pre-menopausal. So I think that is one segment where, we still are, maybe we are overusing chemo because we don't have a proper test. And so even this test mainly is meant for post-menopausal and not pre-menopausal. So now we move on to the next, and that is risk predictors as per guidelines and recommendations. And we have Dr. Ghanshyam Biswas, and I ask him to please present his data on this.
Thank you, Smriti ma'am. So I think Dr. Devrat has nicely alluded, and many of the slides will be common. So next slide, please. And we do understand that breast cancer has just replaced lung cancer in regards to incidence. So not only in the Western world but also in India we see breast cancer has become a #1 cancer. So next slide. And so one of those 5 common causes of cancer related death. Next. The Indian statistics also looks like the same, that breast cancers superseding many other cancers in females. Next. And you look at the mortality and the morbidity regarding breast cancer. Next. So are we different from the West? So next. So we'll agree that our patient population is a little younger, so we have more T size, more tumor nodes, probably in advanced stage. Next. The most important here is that if you see the Gala type, which is the breast cancer, the hormone positive, probably we see lesser as compared to the global scenario, whereas the triple negative and HER2 positives are again much more common for our population as compared to the West. Next. Next. So different prognostic factors. Next. So for years together we have relied on clinical factors and the pathological factor, the we see from the reports. So beyond that, there are tissue markers, there are polypeptide markers, and then there are plethora of gene expression profiles, what we've been discussing for the last half an hour or so. Next. So this one already we have seen from the Devrel slide. So the NCCN 2023, starting from Oncotype DX to the MammaPrint and then Prosigna. So most of these are prognostic. Next. So do we need prognostic tools? So if you don't ask for genomic profiling, then probably looking at a clinical characteristic or pathological parameters, so probably 2 out of 10 patients you won't offer chemotherapy. So otherwise, but once you do a re-stratification, you find that 70% of these HR positive patients and HER2 negative, so who are up to 3 nodes and T1, T2, so might fall into low risk who will not require chemotherapy. So these prognostic tests actually help whether to add chemotherapy or not. So currently used re-stratification tools, so it can be a traditional prognostic which age, tumor size, grade, node status. So still we consider that in most of our patients, especially when the whole country is moving into a government schemes. So an ISC based tool has just taken over. So where KI67 again, which is so variable from lab to lab, so luminal A and B, and so we have just accepted an ISC4 for the last few years. Then the online tools which are available, and then the multi-gene. So Oncotype DX for Dr. Arya, so 100 of patients, so in my maybe in 18 years of practice, not even double figures. So then MammaPrint, so Prosigna and EndoPrint. So I'll just share one of my Prosigna experience. This was a pre-COVID in one of my own colleagues' wife. Next. So we have come all the way from traditional methods to biomarkers and then ISC4 and those online tools to an omic base. So I will talk about Oncotype DX, MammaPrint, Prosigna, EndoPrint again. So Smriti Madam, so most of them have focused on premenopausal, most of them have not included, many of these have not included Asian patients and especially Indian patients. Next. So these red, so are like EndoPredict, Society Myriads, MammaPrint, Agendia, Oncotype DX is genomic health, and we are talking about Prosigna or PAM50, which is based on nanostring, which Lilac got it last year. Next. So Oncotype DX and the Prosigna, these are basically RT-PCR, and we have heard from Dr. Arya also, these Prosigna, we look at the RNAs and the MammaPrint and the blueprint, so these are basically the arrays. Next. So the first generations prognostic tests are MammaPrint and the Oncotype DX, and the second generation which includes the clinical parameters also EndoPredict and the Prosigna, what we are talking about, and then the IC based treatment, that is CanAssist IC based 4. Next. So these are different genomic expression profiling. So we looked at Prosigna in a node negative, we separate them as low, intermediate and high risk, whereas in node positive we separate in between a low risk and high risk. Next. So why do we need prognostic tools? Next. So over-treatment can be a problem. So deterioration of quality of life, increased toxicity, long-term side effects. The goal is to reducing over-treatment in breast cancer patients with optimized therapy. So many a times we are in a dilemma, especially patients is frail, elderly patients with comorbidity, and somebody with a VIP syndrome. So definitely financial and physiological toxicities cannot be ruled out. Next. So this is one of my own relation colleague's wife. So a premenopausal 42 years. This is just pre-COVID. So when Prosigna was done through core, and it was a mammoth cost. So I think at least half the cost what we have with Lilac now. So this came as a low risk, but again, so this was a left-sided breast tumor, T2N0M0, grade 1 tumor. So only she was a menstruating lady, 42 years, without a comorbidities. So we decided that we'll put her on tamoxifen for 5 years. And since it was a breast conservation, she took radiotherapy. And so multiple consultations to other colleagues, and then she received chemotherapy 4 cycles. So initial 2 cycles when Akanji or IV Akanji was not there, so she had grade 3 CINB. In the 3rd cycle, she had a symptomatic hyponatremia, and the 4th cycle symptomatic neutropenic fever. 6 months down the lane, so when she has completed chemotherapy, radiotherapy, and almost a few months of tamoxifen, she landed up in a cardiomyopathy. So she came in the early morning with breathlessness and admitted. We thought of a pneumonia or effusion. The ejection fraction was 34%. So this was a young lady without any comorbidities, absolutely 55 kg, so no high body mass index too, but again, so unfortunately she landed up in a cardiomyopathy because we did not respect the report, and so we did it, but we did not respected this report, and we landed up with a toxicity. Next. So limitations of available prognostic tools. Next. So again, so what Madam alluded, so many of these, most of these are actually targeting a post-menopausals, and many of these, the Asian population who are underrepresented, and so, and most of these tests were developed in the far US and the Europes, and as we have seen that many of these are not into the Indian guidelines also. Next. So there is a huge difference. So you can see those red bars. So in the Asian population, if we talk about this MAMA print, so they represented probably the low risk were less represented. So you can see the tall bars are showing high risk. So as compared to the Western world, so the Asian populations looked different. Next. So this is, we have already seen. Next. So what prognostic tools we have in our hands now? So next. So what is common between these two has been Tanya. So Tanya, so can assist breast. So probably we have just gotten we are used to this test for some time now. And now, so after Lilac has got this Prosigna, I think those, so they were rightly said, so those who cannot afford Oncotype DX, so I think so this is the best way to put your patients on Oncoprecise risk predictor and see if your patient will require additional chemotherapy to hormone or not. Thank you so much.
Thank you, Dr. Ghanshyam Biswas, for that presentation. And now I request the program director, Dr. Sandeep Bipte, to take over and carry forward the proceedings.
Thank you, ma'am. I think without wasting time, we'll move to next event. So I'll request Dr. Garvi Chitkara to have present the case. I think interesting case he had.
Thank you very much, Dr. Bipte. So I'm going to present 2 cases here, both of them who've had genomic analysis for risk prediction of the tumor, and one is with Oncotype, the other is with Prosigna. So I'll begin with the one which we did with Oncotype. Okay. So this is a case of a 70-year-old post-hysterectomy lady. She presented to us with a right breast lump for 2 months duration. On examination, had 3.3 centimeter mass and 1 centimeter, 1.5 centimeter axillary lymph node, which felt positive, and rest of it is for the purpose of surgery. Next slide, please. So mammogram showed a single tumor. Next slide. There was another hypoechoic lesion measured, seen at 7 o'clock, which we biopsied later on, which came out to be negative. And her core biopsy was of the main tumor was invasive ductal carcinoma grade 2. Estrogen and progesterone receptors were 8+ and 8+, HER2/neu 1+, and Ki67 was 35%. and there was no evidence of metastatic disease. Now, before I go on to the next, let's begin the discussion on, now with the Ki67 of 35%, what is the implication? How much do you trust, Smriti ma'am, how much do you trust a Ki67 in your practice?
See, for the want of more affordable tests, we have been using Ki67, but only from very established laboratories and pathologists, not as a routine. So if it is very established pathologists, then only, because there is a lot of interpathologist variation in Ki67. So I mean, it's would be called a poor man's test, but otherwise, there's a lot of variability.
Agree. Yeah.
Perfect. So next slide. Next slide after this. So, like ma'am said, Ki67 value, before neoadjuvant chemotherapy was a significant predictive factor for effectiveness of chemotherapy. Rest, everything else to be able to decide, it becomes very difficult. And like ma'am said, there is too much of variability between the different labs, different pathologists, and unless I have full confidence in a lab and the pathologist and the way they handle their samples, it will be difficult for me to take any decision based on Ki67. Next. So, would you offer neoadjuvant chemotherapy, Dr. Bipte, or upfront surgery for this patient? She's ERPR positive, just to remind, it's T2 lesion, ERPR positive, HER2 negative, single node positive on clinical examination.
So maybe she's an ideal candidate. Hormone being positive, upfront surgery would be a better option. Yeah.
Yes, sir. So we went ahead with an upfront surgery. Next. Go ahead. Next slide, please. So the patient underwent right breast conservation surgery with a sentinel lymph node biopsy, and because of the location of the tumor, we had to have a thoracoepigastric flap, which we did, and it came back as 2 centimeter, 8+8+. IDC 3, although in this, which was initially IDC 1, and Ki67 remains 35%. Clear margins, LVI negative, no EIC. Sentinel lymph node was positive, hence a complete axillary dissection was done, and she had 3 out of 17 lymph nodes positive. Now, the wound healing was uneventful. Next slide. Pre and post pictures. Next. Now, as per what we've been practicing for a long time, Dr. Advait, would you offer chemotherapy, or would you offer a genomic analysis for this tumor, or endocrine therapy without a genomic analysis?
So she's 70, it's a T2N1 disease with a Ki67 of 35%, ER positive, PR positive, which are strong positive, all-red score of 8 on 8.
Yes.
And HER2 negative. Patient is fit. Yes, before the results of RX Ponder, we would have offered chemotherapy for this patient. But now with the advent of the data from RX Ponder, which has also opened up genomic profiling for these group of patients, wherein you have 3 or less than 3 lymph nodes positive, one would look at offering this patient a genomic test to find out what is the risk of recurrence. Especially because at 70 years of age, one would definitely want to avoid the toxicities of chemotherapy at that age. The benefit of chemotherapy, if we look at these risk predictive models which are there, would be somewhere around 8 to 9%, which would almost be the same as what benefit with the hormone therapy would be. And given that the life expectancy at the age of 70 with diagnosis with such a type of breast cancer would easily be another 8 to 10 years. We would, and if she has no other comorbidities, we would look at offering the best option for her.
So, Dr. Ghanshyam, any choice of genomic analysis, or there's wide array available now, as in, like Prosigna is FDA approved, we have Oncotype DX where there's.
So I come from a tier 2 city where out-of-pocket patients, any of these tests, even the lowest possible rate is also difficult. So if I ask 10 patients, so I don't think at this moment 20% turnover is there. So if somebody can really afford, so then all those that's available, you can do the best. Otherwise, now we have two options. So now the Prosigna is there at a much affordable cost. So definitely, I will opt for that.
Okay. So we went for Oncotype DX at that time. Next. So ideally, this is a node positive patient, like correctly put. Before the study, we would have definitely given her both anthracycline and taxanes if she was tolerating it well. And now with the era of genomic profiling, I think it's not correct if we go, and if the patient is affording, to go ahead and give chemotherapy directly, we should be able to save them from chemotherapy as much as possible. Pardon my words if I'm trying to. Yeah. Next slide, please. There are too many medical oncologists here. So our responder trial, which Dr. Advait alluded to, postmenopausal women with 1 to 3 positive nodes with a RS score of 0 to 25 can likely safely forego adjuvant chemotherapy without compromising IDFS. This so for premenopausal 1 to 3 nodes, like Madam said, there is likely benefit of chemotherapy, and in that subgroup we really do not have any test which can give us a good answer, and the data available from Oncotype DX also is very small. Next slide, please. So we did ask for an oncotype, and this is the score which came back, and the recurrence score was 9. Patient avoided chemotherapy, was started on aromatase inhibitor along with local regional radiation therapy, and she's still under follow-up and she's doing quite well. Next slide. So I think that question's already answered. For 30 years we were not going to do this. Next. So this is the second case, which is 61-year-old postmenopausal lady presented with a left breast lump. On examination, 2 centimeter mass with no nodes palpable, no family history. Next slide. Clinically, mammogram showed same inner quadrant 1.6 centimeter with axillary lymph node which was 1.3 centimeter but asymmetric cortical thickening by its 4C. Biopsy was IDC 1, 8+, 8+ HER2 negative, and Ki67 of 8 to 10%. Next slide. She underwent a left breast conservation surgery. PT came back as 1.8, IDC 1, PNI, LVI, EIC negative, 0 on 3 nodes on sentinel lymph node biopsy, uneventful postoperative wound healing. Next. So now this is a relatively easier call to take if we are not talking about genomic profiling. Would you consider genomic profiling in this case? IDC 1, so she's T1C and N0. Is this a case for genomic profiling at all, madam?
So actually, when you were presenting the case, that's exactly what I was going to say. There are certain patients where you would not offer it, and like this, you said her age was
61.
Yeah, 61, and nodes negative, and grade 1 tumor, and 8 to 10% can 1.6 centimeters. I wouldn't offer her the genomic testing.
I think we were in a dilemma there, and when we have some patients where the...
But we always discuss with the patient.
Yes, so we did
It's always an informed decision.
So we had this discussion and they tended to bend towards genomic profiling. But the affordability was again a little bit of, they were not sure what they could do. So we put the whole array in front of them, as in these are what are available, and they chose to go ahead with Prosigna. Next slide. This was her score. She came back as 41.5, and looking at everything that we had, and Dr. Advait was involved in this case. Next slide. We also did the online predictors for her, and the benefit you can see is 0.2% with chemotherapy at 5 years and 0.6% with chemotherapy at 10 years. We decided not to give chemotherapy. She is on hormone therapy, doing well. So in our practice, how often do we use, like you said, this is freely available. Do you use online risk predictors?
Yeah, of course. Some patients will definitely.
And how about you, sir?
We always did with the oncology. But generally, it's case-to-case based, right? even we have some borderline cases we do use, and like the first case, yes, it makes difference, but second case, we need to have a choice, right? So I think we are emerging in the care.
Shruti, would you have used the same online predictor for the first case, where 3 nodes positive?
I would have preferred a genetic based test for the first case, because if she was not able to afford those, I think so she would have been a candidate for therapy, considering she was 3 nodes positive, grade 3 disease, T2N1. But because now we have better markers, I would have gone for that, then going for clinical online predictors for that case.
Perfect. So
Just one comment from my side, because that I have experienced absolutely with a study altogether. So basically online predictor versus any kind of test, prognostic test, be it IHC, be it any genomic profiling, there is always a question, should I putting it aside if it's come high and get it into the chemotherapy, or should I be looking through the online cases? Even in Devrat Arya's slide, you see 52%. That 52% came. Similar experience I also did have, like not with Prosigna of course, but when I was with Canasis, but similar experience I did have, that when we observed and we have started observing that in our, because everything that comes low or everything that is coming high or intermediate, we are doing an online calculations for every patient for Prosigna also. So over there it is a similar percentage which shows high, it is actually not high, or not, maybe lying in the intermediate zones, and many factors like comorbidities or the overall GC, like where the patient consent, very important, is the primary reason, and of course the affordability to go ahead for that. So going upfront, maybe sometimes when intermediate comes in and then using a online predict is possibly could be the algorithm when the affordability of the test increases and the test price also comes down in Indian market, could be the possible algorithm. But going upfront for a online predictor and not offering altogether and a test which may the patient go for it is possibly something we are taking a decision.
Completely agree with you.
There are
another point. Yeah, ma'am.
Ma'am, please.
No, there are certain patients, I mean, we've had a lot of discussions during year-end review and all that. There are certain patients you can very well say that you don't need a test.
Yes.
You know, so that's a very, but as I said, it's always an informed decision, but it's very important to remember
Madam,
that.
frankly, 2 years back, I was working with Tata Hospital, and at that time, there was no question that I would have even thought about a genomic analysis for the patient, the second patient, not at all. But here,
That's what I said, only for the second, not for the first.
Not for the first one. Maybe even for the first one. I would have directly offered chemotherapy,
yeah.
because our responder was relatively new at that time, and we didn't have a lot of Indian, we were not sure about how much of Indian data was in it, but any which ways. So we did an online prediction for the second one also, and I completely agree with you what you were saying. But you know what happens where online predictors are placed in the mindset is like, this is not going to cost me anything.
Correct.
Maybe if I am already leaning towards not giving chemotherapy, and if it validates it, I will not ask for a genomic. You know, and here I am looking at a patient who is trying to bring in, pay out of, most of them are paying out of pocket, and especially for risk predictor models, there is zero support from the insurance. So, you know, I have to think that she's undergoing a surgery, which is going to cost a certain amount, and then she's going to undergo chemotherapy and even targeted therapy. Or targeted therapy, let's rule out, because those patients don't go for this thing. And there's then radiotherapy. In that, something which has been pushed in, which is equal to one of these, is very difficult for the patient to. So then, you know, the algorithm changes, and instead of doing a online, instead of doing a genomic profiling, we end up doing a online prediction. So I'll just show you the online prediction of the first case. Next slide, please. There you go, like he correctly said, at the end, and this is only with anthracyclines, 4.1% chemotherapy benefit and 7.8% at the end of 10 years. So that is the kind of benefit that is being shown by an online predictor, where genomic model has shown a risk score of only 9. So what we joke about a lot of times is tensionality of time, where, when you know that the disease has been there for a long time, when you know that the patient is saying that I've had this lump for 2 years, and now your axilla is coming positive, which is 2 or 3 nodes, you're also trying to consider maybe it's not a very aggressive disease. It's just because the time has elapsed and that's why this has happened, and it's not because of the aggressiveness of the disease. So,
I think another thing what we need to understand is that whenever we are looking at these clinical risk prediction models, they are sort of a stepping stone towards deciding the therapy, to counsel for therapy, and also to counsel the patient for doing the genomic test. Another thing we should always remember is that if we have asked for the genomic test, then the genomic test always trumps the clinical predictor. Yeah. Because at times we do get into a situation wherein, especially with the second patient we had this, that the clinical risk was so high, but we got a marker, the first patient, that we got a risk score of 9, in which we actually had, during our tumor board discussion, we were thinking what to do. I said, then there we had this decision that, okay, if we believe in the genomic scoring, then let's follow the genomic score and forget about the clinical risk score or the predict NHS, which is showing that there is an 8% benefit, which is a significant benefit. So I think it becomes very important that an MDT is there where we can thrash out each other and then finally speak to the patient in a common language, which actually helps the patient much more to understand the things. Because many a times they are lost once they get the report. They don't know what is there. And as a practice at Max, we both are doing predict NHS scoring for all patients. All patients. Just to maintain our data and see how it actually correlates. And we've had about almost 200 patient data so far. Yeah.
And how about the data, how it's looking, like the concordance?
Actually, I think
the follow-up period is too short right now. So we are prospectively following them. It's just been 2 years.
Yeah. So two things, of course, very important part of it is, one is the molecular subtyping is a major part, which Prosigna offers, and unlike other tests, it's not about Prosigna, I'm talking about from the patient point of view also, because as I was trying to show in the first slide itself, our validation is also showing the low score patients that has come in, 68% of them are luminal A. So the molecular subtyping, the aggressiveness, the tumor size, the nodes affected, post-menopausal, that is far more important, because if you go back to the history of risk predictor, why it was incepted, it was already for those patients who are actually elderly and having comorbidities, and overall GC has gone down, and they should be avoided from the chemotoxicity. So that's how it plays a role. And even giving hormonal therapy alone, the 7 years, it's itself a cause, and withdrawal after 7 years is itself a cause for a recurrence. So anything that we go, because online predictor, they're not having the DFS data of 10 years. Which is the coverage period of the 7 years. So possibly that is a major reason, that is the disconcordance that comes in for the online predictor.
Yeah, so there is actually a scoring system called CTS5, which you use beyond 5 years of hormone adjuvant therapy. This is by the Oxford group, and that is their meta-analysis on basis of which the algorithm is there, which again categorizes patient based on clinical criteria into low, intermediate and high. And if they are low risk, you can stop the hormone therapy at 5 years, intermediate, high risk, you would continue for 8 years. And that is something which you do at the end of 5 years and then assess the risk of recurrence between years 5 to 10. But obviously these are all again clinical markers. We still do not have genomic markers to look at which patient needs an extended hormone therapy.
Second thing, I know that molecular subgroup is important, but in the clinic we don't use it, so it is of no consequence. Okay, for research purposes or trying to look at that, so that particular thing is mainly for research, but in the clinic we don't use that.
I think we have a lot of discussion going on. Yeah. Interesting cases both are, right? But as a standard practice, we offer the test first and then online predictor, I think, as a second option, right?
Yeah.
So
I think that was my last slide. So
thank you, Dr. Garvit, for your interesting cases. I think Dr. Sareen is also here. So good evening, sir. So let's move to Dr. Sareen for his next case presentation.
Dr. Sareen, you'd have to excuse me. I would have loved to be there, but there is some personal thing, so I have to leave.
Sorry, I could be earlier, another meeting going on.
Okay. And you too, Dr. Datta. I would have very much like to listen to you.
I thought I will use my laptop, but they won't get it from there because it is on the Google Drive. I think Google Meet.
Yes, sir.
So they're just doing that. So what I will, in the meanwhile, I will just tell what, how much time we have, 25 minutes, 30 minutes. So for this, I have used actual consecutive 10 cases that have come to the genetics clinic, and it so happened 7 or about 5 or 6 of them were breast cases, 1 or 2 ovary and 1 or 2 some other cases. So I will show what was the, the case capsule just in brief, and whether you would do genetic testing or not, germline I'm talking about, and what would you suspect or expect to find and what we found, so this is real. And then after those 10 cases, I will have just 3-4 other cases where to some of the things that have not been covered in those 10 cases. So these are real cases, 10 consecutive cases, okay, which have come to the cancer genetics clinic. And while it is being loaded, so our genetics clinic is getting busier by the month now. Every day we get 8 to 10 new families. So in a year, in the last 12 months, we have registered more than 2,000 new families. And germline testing, earlier we started with Sanger, then limited panels. Now we do in-house germline panel. And last 1 year we have done more than 2,000 germline panels, targeted panels. So we use a panel called Sophia, which has 2 types of panels. One is 26 genes, which all the breast cancer genes, breast, ovary, and endometrial and Lynch syndrome genes, it has high depth. So for copy number variant analysis is very confident copy number. But some of the rarer syndromes, then we also have a 84 gene panel and 113 gene panel. What happens? Okay. So the question comes whether you will do genetic testing or not. And I am telling you from this end when they have reached the genetics clinic. So there are occasional patients, the doctor has not referred, but the patients land up asking, हमको genetic testing करना है क्या? हमने कहा डॉक्टर ने भेजा कि नहीं, डॉक्टर ने नहीं भेजा, हम करना चाहते हैं. Sometimes they want to do. Then in that case, you don't just ignore them. You ask them why they are there. And sometimes when the genetics clinic, they start telling more than what they have told in the oncology clinic. So when as many times I have seen them in the breast OPD, and then I've seen the genetics clinic, so they are different people. So suddenly started telling more, because you give them time, and then they are also expecting that they'll be telling. So that is one scenario. Otherwise, all are referred. Sometimes, just yesterday, I had a patient was referred by our gynec oncologist for genetic testing, and patient said, "नहीं, मेरे को नहीं कराना है, high grade serous ovarian cancer." So they said, you go to genetic and let them speak to and let them write that patient does not want to do genetic testing. Because many times this is happening that it is a classical indication, patient refuses, and later on someone else would come. So, okay. So then we had to write that, it is indicated, but patient does not wish to do it. It's patient's choice. Okay. How do we move the slides? Can we?
You can say next slide.
Next, okay. So, I mean, this I don't have to tell to this audience. Wherever it is red, it is pathogenic germline. And I think that's where we get a lot of issues when we have a missense variant. Because missense variant in tumor suppressor genes, in oncogenes mostly it's a missense, alteration, at one codon which is changing, and specific codons, codon 12, codon 13, codon whatever it is. In tumor suppressor genes, missense variants are most troubling variants. Many of them are polymorphism, a few of them are pathogenic, and a vast majority of them are variants of uncertain significance. And it is, I think, a difficult counseling for anyone to do. And if you have a difficult patient with a VUS, you have had it. And the most difficult kind of patients are those in whom genetic testing is not really indicated. There is no significant family history at onset, but they want to do that. And that is the only patient you will find a VUS, and then you have had it. Okay. And that VOS may be in a gene which is not at all relevant, but for that lady doesn't know. She said, kuch to mila hai. Okay, so I think next. So pathogenic or benign and the variant of uncertain significance, I won't, and I think as doctors many times, like initially when we were doing MRI scan, I remember, we were not able to interpret what it is, we would go by radiologists, even PET CT when it had come. But at some point of time, we started learning to see it ourselves and understand for ourselves. I think same is for genetic test reports. You can't just go by what is written. You will have to, I mean, there's no way out but to actually understand what is the variant, what is expected to cause. Because in India, the heterogeneity of labs is so much. Some labs are so dangerous. They are actually, sometimes looks like the report is like a, it's a dynamite. Most, unless until you are alert or you are knowledgeable, even if you are knowledgeable, if you are not alert, you will be, misled. And the action finally, you will be caught, the doctor, not, the lab. The lab would have disappeared by that time. So all the NGS labs, there's so much of rotation coming, going. Next. No, really. I mean, they're just cropping up. कितने हमारा NGS हम 12,000 में कर देंगे, हम 8,000 में whole exome कर देंगे, इतने में 15. I mean, how can you do that?
Mostly they are outsourced to some companies.
Yeah, whatever they are doing. So I'm saying, so you don't have a choice. And because it's an expensive test, you can't ask to repeat kar lete. It's not like CBC. Okay. Or you can't get it reviewed also. I mean, where will you send for review? Like if a MRI, you can send to your radiologist, isko dekh lo yaar, iska kya hai? Pata samajh mein nahi aa raha. But
if it is being outsourced, the cost would be even higher side. So I don't know how.
No, outsourced. Many places. I mean, they can many places.
Repeated. So it's why different people are asking for it going to same lab.
Yeah.
Distribution.
Yeah. 10 people are standing with one lab.
So this shows that the number of families, first 1,000 cases in our cancer genetics clinic, we give them CGC 1, 2, 3, 4. 8 years it took us to get first 1,000 patients. Then 2 years. Now every 6 months we register 1,000 patients. That means this is this. So this year we'll have 2,000 patients. And I think there are two reasons. One is that now that we are doing in-house germline NGS panel, so many treatments are guided by that. Families are aware, doctors are aware, and so many things have happened. I really can't pinpoint one thing, but it has taken up. I think next year we will have probably 3,000 new families. So it's like a entire one unit. So I have got 6 genetic counselors with me in the lab. Dr. Poonam Gera, both of us report together, plus 4 or 5 people in the lab. So it's like any other department it has become. So it is so busy. Next. So I'm just showing the first 1,000 cases we did with the NGS panel, 1,000 odd HBOC cases, either they were early onset or they had a family history. And about 1/3 of them we found a pathogenic mutations. 26% of the VOS rate, germline. But this VOS rate is coming down because our own internal database. So the particular variant initially we called a VOS initially, but now we have seen that we have found it in, now we have around 3,500 patients whom we have done germline panel. If that variant was seen in 6 people we had found, and in 2 of them it was occurring along with another pathogenic, we put it as a likely benign and we don't even report it. So our VOS rates are coming down. Initially it was around 20%, now it has come to around 10%. So, and as your database increases, it will come down. That is what has happened. Like in Myriad Genetics, which was a lab which did all this thing. In Caucasians for BRCA1, 2, their VOS rates is less than 5%, but in Asians it is around 15-20% in them also, because they don't have that many Asian patients. And Asia is a very heterogeneous. Asian means what? There are different communities. Next, please. And in the BRCA, in the mutations with this HBOC, majority were BRCA1, BRCA2, plus some other genes also, P53, mismatch repair, ATM, etc., etc. So this comes when which panel you should use. So I think BRCA1 and 2 sometimes we do many times, especially ovarian cancer, just for this thing for treatment point of view, because for other genes the data for the response is not as robust. But I think in general, by default it should be multi-gene panel. So for breast cancer there should be at least 12 to 15 genes, and sometimes the family history, the lady may have breast cancer but her someone else in the family has some other cancers. People don't clearly say it was ovarian cancer. They will say uterus cancer. So sometimes some people will say uterus cancer, some will say pet ka cancer, so we do not know what it is. So it is best to have a panel which covers at least Lynch syndrome and Lynch syndrome, HbOCN, P53. Next. So this is, I mean, ovarian, this is where I agree with NCCN. You know, many places they just say so much. They said you test all high-grade serous ovarian cancer. So when there is a family history, this is our own data, then if they're below the age of 50, almost half of them had a germline mutation. Majority of them were BRCA1/2. Over 50 years, then 33, and even in absence of family history, irrespective of age, about 25 to 30% have a germline mutation. Most of them are BRCA1/2, sometimes you know, some other this. So I think this is where NCCN has got it right, that irrespective of anything, it is high grade serous ovarian cancer, do it. Next please. So now I will show the 10 consecutive cases, and then I would like your opinion. I'll tell you what actually we found. So this case is, so this is our report, this I will give. So bilateral breast cancer at 49 and 50 years. And it was a triple negative invasive breast carcinoma grade 3, and her brother and father had oral cancer and tobacco habits. You know, why I'm asking tobacco habits, what we've realized that in BRCA2 especially, some cancer which is not known, not esophageal and oral cancer, absence of habits in BRCA2, we have seen quite a few cases in BRCA2, not so much in BRCA1. So genetic testing, would you advise in this? Anyone who says that no, you would not advise genetic testing? Patient has not asked, but just so it's a classic this thing, but and family history hai wo pucha. Normally people many times family history only ask of female cancers, किसी को ovary या breast हुआ था, यहाँ पे तो oral cancer. So but whatever we find, we just note it. Next please. So what we found in her is a BRCA2 mutation. Okay, so this is a BRCA2 mutation, and of course in this case she has bilateral breast cancer, depending upon what her stage of cancer, whether she's a case for PARP inhibitors or Now what is happening, more and more of them are referred initially at the time of diagnosis. So by the time their adjuvant treatment or NACT is just going on, first we have the report, so change of therapy is possible. Earlier, most of the time the report would come after they have finished all treatment, and it was only an academic discussion. So actually now it is involved discussion. So based on this, then we give next case. So this case, recurrent ovarian cancer, first diagnosed at 43 years, and it is a classical high-grade serous ovarian cancer, no family history. So I showed in that slide, in these cases, about third of them we expect that there will be a germline mutation. So genetic testing, now this question comes, whether you will do somatic or germline, or both, in which order? Any one of you want to? In your practice, what do? You do germline or somatic or none or both?
So ovarian, prostate, so I'll ask for a somatic, then genetic, then germline, all breast germline.
I think that is a common practice, but in our hospital, because see the cost and the other factors are also there, and because our yield of germline is quite high. If the yield of germline was only 5%, 10%, then 90-95% will not find. So we do germline first. Within few weeks, we have the germline report, and the cost is much less, and the maximum. So next.
So all these germlines are so Sanger sequencing or NGS?
No, NGS. These are all NGS.
All NGS.
These are all NGS, germline panel. So the 26 genes. So in this patient, there was no mutation, but we just mentioned 70 benign, likely benign variant. All of us have variants. That's why we are different. So we mentioned. Some patients want to know कि हमारा अंदर कौन सा variant मिला हमको चाहिए. So we provide to them. No doctor has ever asked, but some patients are curious to know. So. No, but even in absence of family history, it's like about 30% we find a germline mutation.
But that need to corroborate with the family, some kind of like incidence.
Not always. So now what has happened is that earlier we were only going by family history. The classical model was strong family history, genetic testing. Now you say many times it is half the time it is coming from father's side. Father may be a healthy carrier, or the family history was unknown, or it may not have manifested their intermediate variable penetrance also.
But then what's your advice for you are also likely opening a Pandora box?
Of course, now there is a found a mutation, her siblings and her children. Occasionally there is a de novo mutation which has occurred with that person, but generally it is either from one of the parents. So Pandora's box, yes, but it is a real risk. It is not something wish it away. If her daughter has a BRCA1 mutation, I mean, you can't,
Just the box is open, so
it's open.
So do you do a somatic mutation if you get
So
a
now,
germline
if
negative?
this case, so she has to have, I mean, now it depends on the clinical context. If from a treatment point of view, we need, that information, then obviously somatic and then, HRD, whatever you do.
Yes.
So that is, so this is the first quick pass. If you find a mutation in this, nothing else is required.
Yes.
Job is done. Next, please. So in this case, breast cancer at 34, TNBC, no family history of cancer. So you all would recommend?
Yeah, we would less than 40 TNBC.
Less than 60.
So the NCCN says 60.
Less than 60.
60.
Initially 40, then 50,
It was
then
40,
60.
then 50.
It was 40, then 50,
now
then
it's
60.
Yeah, 60. So, and no family history. And our, we have genetic counselors, so the family history,
Increasing the age.
they are trained in eliciting family history. When they say no family history, means no family history. Okay, next. So this was, nothing was found. So in this case, anyone would want to, get deeper into anything?
MLP.
So in this case, so actually TNBC, our own internal data says that in absence of family history, just early onset TNBC, the germline mutation is around 10%. It is not 25-30%, unlike high-grade serous ovarian cancer. So it is around 10%, at the most 15%, if it is unilateral. And of all the BRCA mutations, only about 10% are copy number variation, which will be picked up by MLPA. So chances of her having a MLPA finding is only 1%. So if she is very keen to know or something else, then yes, obviously that is. So we have written there, so the test that we do, because it's a high depth and the bioinformatic base, so there is a CNV analysis. So in this, when we say that there is no pathogenic, likely pathogenic or copy number variation or any variant of uncertain significance identified in the 26 genes tested. So that means nothing. So whatever we have found in her case is only 67 benign, likely benign variants.
Sir, in your data set, does this percentage of having a mutation positive vary as per the age, because we have a younger TNBC population as compared to the...
I mean, in general, you will see the younger the patient is, there's a higher problem. If you have 100 women who are younger, with the same kind of cancer and family history, there will be higher probability. Next. So, go back please. So in this case, I mean, I wouldn't really, agonize, tell them, we suspected, we haven't found anything. I mean, if you are very keen, we may want to, some people are there. You could do a larger panel or MLPA, but most of such cases, this will stop at this point of time. And I tell them that in case of the treatment point of view, whatever required, then your doctor may ask to do testing on the tumor. So they know that that is an option.
Even in this younger population, we had MLP, and which was come to be negative in a lot of cases.
Yeah. So
unlikely to happen that MLP done and it will be positive. Very rare. I haven't seen that.
So MLP, I would strongly recommend. First of all, you see which lab it was tested, how it was tested, whether their NGS test was validated for CNV analysis. So anyone can do CNV analysis. There's so many things, but whether they did a clinical validation, if there were 20 CNVs, was it confirmed on MLP all 20? So what is a false positive, false negative rate? False positives are, you would find in odd genes. So you will know this is false positive. This could have a false negative. So if there's a noise, if they were not run at high depth, if the capture was not good, I will show you some cases, our copy number variant analysis. Next, please.
And how do you deal with the anxiety originating due to the POS? Would they want?
That's why we have a separate genetics clinic and genetic counselor. They talk to them. Believe me, they talk to them for 2 hours. Sometimes I get, kitna kya baat kar rahe? But they have to talk to them. We cannot talk to them. So the genetic counselors, not all cases, every 10th case you will be there. You as a doctor, you can't handle. You need genetic counselors, which I am lucky to have many genetic counselors. So
it's difficult at times in community practice to explain to them that, look, we are not the ones who are qualified. You need to speak to a counselor and get this sorted out.
Yeah.
Because we do come across certain situations wherein the entire family turns out positive, reflex testing is done, and about 7 or 8 of them are sitting in front of you. Everyone bombarding questions. They said, look, we are not the ones who are really.
So and it has to be individualized.
Yes.
You can't do just
Yes.
group session. Sab log ko bata diya. So
They can't do that. And they, unfortunately, they expect that.
Biggest dilemma is a young patient, triple negative, positive family history, and you find a BUS. Then the doctor is in a dilemma.
Yes. Yes. ये क्या है? Yeah, it does happen. Yeah, I mean,
I've discussed this 4 days back with her, and we found like a family which is BUS. All of them has.
All of them.
So obviously, that is
Yeah.
pathogenic, and
pathogenic.
it is going to be reclassified as pathogenic. But that's a big issue when you're discussing, and when you draw a pedigree which is. And when, 2 generations ahead, the pedigree would be 7 children in 1 generation, and then each of them has got some six children. So.
see, but I think in this day and age, you can't run away from it. I mean, it is there. You have to deal with it. You have to figure out how to deal with it. So this one is breast cancer, triple positive breast cancer. So that was triple negative. This is ER, PR, and HER2 also amplified. All 3. So any different in approach, again no family, and these are consecutive cases as they have come to the genetics clinic, and we have agreed to do the genetic testing. None of them were that the patient forced upon us. नहीं हमने बोला नहीं, उसने बोला करो.
So normally in all clinical trials, they have excluded HER2 positive trials. HER2 positive breast cancers, they have excluded from germline. So irrespective of age, but there is a recent paper in 2021 which showed that. So according to popular belief, so even HER2 positive patients, the rate of BRCA is much more than HR positive. Not triple negative, but HR positive. It is a rate of 5 to 7%. But normally we don't do. Even all the Olympia trials also. So they
see those trials, because I think the reason behind that, because they were for HER2 positive, already a treatment for them. So for these other patients, there was no treatment, so they wanted to exclude because they were already on anti-HER2 treatment. So this effect of olaparib would be masked, or all the PARP inhibitors. That's why they chose. So actually, if it is HER2 positive and very young, suppose you see a 24-year-old with HER2 positive, the highest probabilities of P53 mutation, germline P53. In this case, next, we found a BRCA1 mutation. So that's why, you can't just, you have to do it. That's why we don't do only single gene. So we found a pathogenic mutation in BRCA1, and along with that, a VUS in PALB2. So whatever it is, it means once you find a pathogenic mutation in one gene, you don't agonize about the VUS in other gene, but sometimes the VUS in the other gene is also likely to be pathogenic. So in the family member, the question comes whether you will test only the BRCA1 or this thing, because she may have a sister, her mother is there, etc.
Now, especially, sir, with the adoption of adjuvant PARP inhibitors.
Yeah.
I think we are looking at doing this mandatory for all patients, practically.
Yeah. So that's why many more patients.
Many more patients are actually being tested because adjuvant olaparib is now approved.
Yeah. So this lady has.
Patient you would have advised for
even ER positive.
Yes. So that depends upon what stage. Some of them are very early stage. Also, it happens. They are very early onset, so it depends on stage. The Olympia trial was those who had a residual disease or node positive, isn't it? So some of them had a very operated per primarily it is a T1, T1B, N0. So those kind of cases, or a PAT-CR they had.
So Olympia were majority locally advanced.
So they had all comers?
They had all comers.
All comers?
No,
Olympia. I will.
Okay.
Sorry.
See, I mean, normally they would choose patients who are, because there they have a lot of early breast cancer. So they would pick up patients, there will be an event rate. If they start picking up all comers, then they will have many patients with the event rate will be less, the trial will not be positive.
HER2 negative all comers.
Sir, one question. HER2 positive, is there a gene that you would specify? Like if you're testing HER2 positive?
P53.
Younger patient 5%.
So, no, P53 is very common, plus BRCA1 2 also. BRCA1 2.
No,
Yeah.
either of these two, is there a prediction towards
More of BRCA1.
BRCA1.
More of BRCA1.
They were HER2 negative all early breast cancers.
HER2 negative all early breast
Sir,
cancers.
HER2 negative all breast. I mean,
Those who had received local treatment, neoadjuvant or adjuvant chemotherapy, but early breast cancers.
So I have read a paper in which they say HER2 positive are generally BRCA2 having a more worse prognosis.
So if they are BRCA2, if they are HER2 positive compared to ARPR, so
yes.
Compared to BRCA1, ARPR positivity is much higher in BRCA2. That's why sometimes we don't suspect hereditary because it has happened at the age of 55, it is ER positive. You're not suspecting it will be hereditary, but you will find a, BRCA2 mutation. So this one has bilateral breast cancer at 27 and 33. Again, no family history. And it is bilateral TNBC. Answer low ne de diya. MCQ. Next. Please, next. देखो क्या मिला VOS in ATM. Okay, so this is a consecutive, so this is 12-1-2-0-0-5 CGC number, मतलब it's consecutive cases है. So we are suspecting इसमें तो BRCA1 मिलेगा. अभी what we are finding is that, and again there was no CNV, we are finding a VOS in this, and it's a rare variant. It is a missense variant, and earlier there were only 2 submissions in ClinVar. Both of them have called it VOS. So in this patient there is no family history also, so we can't go in the family and check. So what really we do about this case? So I think these are the patients where, as our data sort of increases, maybe we will find this in some other family where we can test if there are multiple members in the family who have cancers, and if all of them have this variant, then we know that this is co-segregating with the disease. That means it is likely to be, disease causing.
There's an ATM card, but there's no money now.
ATM. ATM. So I mean these are real cases. Now this one is,
and considering here the mutation is very, there is a tyrosine 2 mutation, so which is likely to be pathogenic because there is a kink. Cysteine is.
Yeah, I know. So what we do is then we use all this. So we have used 3 mutation predictors, SIFT, polyphen, and mutation taster.
Likely predicted to be pathogenic.
No, so only one of them is predicting to be deleterious. 2 others are not predicting. So, you can run 1 or 2, but see, sometimes you get conflicting reports. Even if all 3 were predicting to be, pathogenic. So, like for BRCA1, the functional distinct, for BRCA1, there is for large part of BRCA1, there is a study which is using CRISPR. They have done functional characterization, which is really very good. It was published in Nature a few years ago. That's but for most other genes, there is none. So you have to go by.
Sir, in a case like this, would you advise an in silico testing or?
In silico also, उसपे कुछ नहीं होगा. We are stuck. Okay, now we are stuck. Now if suppose the sister wants to know whether I have this, what should I should? Because she has 50% chance, her sister will also have this variant. But can you give her any advice? You can just say based on this, all her family, female relatives should undergo high risk screening at least. That we can tell. So it is negative.
No risk reduction, but early detection.
So I'd go a standard chat that it could be either a polygenic risk, or there's a very small chance it is in some other gene, or it is in this gene but it has been missed, etc., etc. But in all likelihood, in years to come we will be wiser. And next please. So case number 6 we have reached. This is breast cancer at 67 years. It was TNBC, and her sister had stomach cancer at 59. So here we have written whatever the patient told, stomach cancer, but stomach means
anything.
Could be anything. Stomach does not necessarily mean gastric. So इसमें genetic testing कोई करेगा कि नहीं करेगा? Garvit, you would. It's 67 pair.
Sir, actually I have burnt my fingers, and right now with TNBC less than 60 I'm asking.
She is 67.
No, I'm sorry. I thought
Yes, 67 है. वो उसकी sister को stomach cancer हुआ था 59.
So with the adjuvant olaparib data, sir, TNBC I would ask irrespective of age. That is we've decided that our threshold should be very low for TNBC irrespective of the age.
What do you all feel you will do? Consecutive case number 6. Let us see what we found. Nothing. But I agree with you, all of you, that we should do it. If we didn't find anything, then we'll say, as such the chance was less. It becomes very easy, if you have done. So
no result is a good result.
No result is a good result. And her I would not agonize because she was already 67. But so usko bola, theek hai, kuch nahi hai. Next, case number 7. And you see how common is breast cancer in the genetics clinic, because we get referral from all over. इसमें से कितने सारे breast cases हैं?
Number 1 cancer, sir.
हाँ. And even in terms of awareness, I think even amongst patients, they also ask now. You know, I mean, for a long time it has been. So this is 38 years pay, ERPR positive, HER2 negative, no family history. Okay, so here the only, again, genetic testing, definite.
She's less than, yeah.
Less than 40 definite. Okay. टाटा हॉस्पिटल में लेस देन 40 वाले कितने केसेस होते हैं पता है ना हम लोग we will be
2 years back no
हाँ so partly I used to tell them सब मत भेजो because अगर all under 40 breast cancer start coming to us
we don't register 5,000
you know that itself will be swamped. No, I'm just telling you. So but we did, and what we find in, there's a VUS in BRCA too. So now in this VUS, sometimes you have to read it in between also when you find something. There's no family history and it was ER positive, not triple negative. So we have still reported it. So this is a intronic VUS, okay? So it is at -13, which is not in the consensus splice region, but it is a little away from that. So ideally we should do a functional study to see whether there is, you know, transcript analysis, whether it is causing aberrant splicing or not, but short of that.
It's also heterozygous.
Yeah? No, heterozygous, all are heterozygous. So earlier 4 labs, 2 labs have called it VUS, 2 labs have called it benign. But I've still included in all likelihood it is benign. No lab will call it benign, especially these labs, unless until they are sure about it using based on that, their internal data. Because it is in a gene which is relevant for her cancer. And plus later on she will get tested at somewhere else, or someone will ask, they will find something telling you to negative reported. So I have mentioned that, and then sort of, but when explaining to patient I have said most likely this is nothing, you know, it is not of concern. So but it is there in case she or someone else, later on her daughter gets tested, if it is found in that telling mother mein to nahi tha, but mother may be tha, and we have just mentioned that. Next. Case number 8. So she is 24, TNBC, no family history. You all will do or not? You know?
Don't ask me.
See, आज से 5-10 साल पहले इनका किसी का नहीं
Nobody was asking, sir.
So no family history, no?
So about 5 years back, patients never used to ask that they wish to get tested.
No, they were not asking, but
almost
the disease
3/4 of the patients who come to clinic will say that, doctor, what is my risk that my children will not have it? That is the major concern which actually asks them to do that. नहीं, but पहले तो सर 1.5 लाख रुपया था, अभी 22-23 हजार में होता है. So that is also हाँ,
फ्री में नहीं करते.
फ्री में नहीं होता.
Tata Hospital NC patient gets this NGS panel for 6,000, big C category 12,000, private patient 18,000. अब patient जो बाहर से आते हैं उसको 20,000. So it is, you know. So in this one we found in BRCA1, not at all surprised. But if we had, I was half suspecting I will find 350, but we found in BRCA1, which is again sort of matches with the next case number 9. So this is a patient, then बीच में एक thyroid आ गया, papillary thyroid cancer, and उसके father को follicular adenoma था, neck swelling था, उसमें follicular adenoma. तो इसका हमारा इसमें जेनेटिक टेस्टिंग करेंगे कि नहीं करेंगे इसका पैनल हमने चेंज कर दिया अभी बिकॉज वी डिडंट यू नो मोस्ट थायराइड कैंसर की जीन्स पे सब नहीं थी तो वी हैव डन अ लार्जर पैनल एंड वी हैव फाउंड अ VUS इन P10 gene. So this you know it's a in frame deletion, that means there is a deletion but only one codon is missing, rest of the sort of protein is there because P10 can cause Cowden syndrome and it can cause thyroid cancer. So this is probably, you know, relevant for her, and based on this, so we will look for. So in this patient, when she would have come, I would have looked at any clinical features of Cowden syndrome. So clinical phenotyping, I think, see, initially we can't do clinical phenotyping for all possible syndromes, but when you find a variant, at least look for that. You know, P10 has, Cowden has several this thing, you know.
Will you advise cascade for this?
Abhi father में I will see whether there is a co-segregation or not, but बाकी लोगों में नहीं है.
No, I mean at least father.
Yeah, father. Next. So case number 10 of 12,000 series का है. High grade serous ovarian cancer at 35. Father had liver cancer at 52 and maternal aunt had some malignancy. तो ऐसे कुछ बोलते हैं, मतलब दोनों different sites हैं. Liver भी पता नहीं liver क्या बोलते हैं, we don't know. when patient tell us कि उनको liver cancer हुआ, it could have been liver metastasis, could have been anything. Like so many patients उनको bone cancer हुआ था. It is bone metastasis. You know, bone cancer is not so common. Sometimes myeloma also they tell bone cancer. You know, so we now know what they mean when they say party. Report result next. So in this we found a VUS in CDH1 gene. I was expecting we will find BRCA1 or something else. We found a, but CDH1 this doesn't sort of match. So, you know, it was very easy counseling. So, VUS in a gene which is not really relevant, उसको counsel करके भेज दिया, कुछ नहीं करना है. Next, please. So now these are some other which are not consecutive cases, just to you know this thing. So some findings and these are non-consecutive cases. कुछ उनसे पहले के हैं, कुछ बाद के. So ये patient है metastatic ovarian cancer at very young age. She has been diagnosed 34 and high-grade serous ovarian cancer. How you could look at it. Her mother died of ovary cancer at 53. Her sister has ovarian cancer. Her mother's sister had breast cancer and others, you know, a lot of cancers in the family. Next. And in this, what we found, deletion of the entire 1, 2, 24 and the 3' UTR. So which is odd. I think it's alag se dikh raha hai. Normally what we find, deletion of 1 or 2 exons or retention of or duplication or deletion hota hai. So this was very odd, but it sort of fitted very well in the with the family. It was like a classical HBOC presentation with the whole gene. Next. So on top, what you see is the NGS based copy number variation analysis, bioinformatic based. So if is there a pointer? Okay. So if you see the top, oh, you have the. So this one is for the bioinformatic based CNV analysis from the NGS. So what they do is, so they take 12 samples, they make a pool, so and they normalize against it. So all others, so these are different exons of BRCA1. So copy number 2, because you should, all of us have 2 copies of BRCA1. So these are all normal. And but in this sample, which is in red, everything is 1, 1. That means 1 copy is lost. There is a heterozygous deletion of almost entire BRCA. So I mean, I am not including everywhere. So in this case, I sort of said, no, let us do MLPA to confirm is it really a true result or not, even though the was fitting very well. On MLPA is done a different kit. There also, the sample is all in red. So this is done by a different method of analysis, coffolizer. So it is a true deletion of the entire sort of BRCA, you know, and including this, almost entire. So this is a true finding. So when you get a very clean result like this from CNV analysis, then you believe it, trust it. If you don't, sometimes it was noisy, you will see those dots were up and down, and then it was there, it was not fitting into matching with the, you know, the clinical syndrome that was suspecting, then it could be false positive. Then you have to do MLPA to confirm.
But Dr. Sarin, with your facility, why would you want to do first? Why not direct sequencing? That would be more revealing.
No, so this will not be picked up on Sanger sequencing.
Why? It is heterozygous.
So because, you know, it will just read 1 normal copy.
No, it will have that noise, right?
No, not noise. So this is not a frame shift deletion. This is whole, utna part gayab ho gaya. It has not changed, not just one part. Otherwise what happens in heterozygous deletions and all, few of the bases have been deleted. So the aage ke idhar aa jate hain, to frame shift, then you will see as a noise. This will not be. The only way to pick it up is MLP, otherwise MLP is. So this is case 12 is triple negative invasive breast cancer at 38, no family history. Okay. So in this case, what we found, there was a P53. So एक P53 बताना था, ऐसा भी हो सकता है. So you can't really you know, say what it will be. And we also found a VUS in ATM, so we will not. Case 3, ovarian cancer, high-grade serous ovarian cancer, father oral cancer. Why I am showing this case? We found in this case, there were not 1, 2 different mutations in BRCA1. So we get bouncers when we do more and more cases. So how can it happen? Though mutation, but it is true. So this is what it is. And initially now we have about quite a few patients who have double mutation, germline mutation. Initially I used to think their phenotype will be very severe, but their phenotype is no different. किसी को मतलब सर पे एक गोली मारो या दो गोली मारो, उसका पैर में एक पैर में गोली मारो या दोनों पैर में उससे फर्क पड़ता है. एक पैर में गोली लगे, person can still walk, both but now this case you see, so two sisters with ovarian cancer, provided ovarian cancer at 61. Her sister ovarian cancer, she died at the age of 46. Her mother died of ovarian cancer at the age of 53. Her brother had lung cancer, but occasional smoker. So this is a case, and this is a recent, 24/7 we decided we'll do this panel, and in this we found nothing. I mean, we was in an APC gene. APC was just incidental finding है, तो वो गया. So what do we do in this case? Anyone?
Just in between.
Will you do it?
Can be the last case because of the process.
Yeah.
Oh, that's not important. I mean, this is very interesting.
Will you do it? It takes MLPA for this. Like MLPA. So I looked at the raw data. Our MLPA is quite confident. Okay, might do it. It's not, but it's a good point. If this had come from some other lab, I would have done MLPA. Okay, because we know that we don't miss. So these are the cases where you will actually think of some exome or something else, and there are many doctors in this family, and it's so common. I don't know why doctors certainly come up in the family. The difficult case you don't find someone is a doctor in the family.
But why totally ignoring the APC in this case? I mean, I can understand.
So APC, what happens? APC has a very clear-cut phenotype,
yes,
polyposis,
and this is heterozygous, and it might
So it's a classical phenotype of this thing, and you don't get ovarian cancer in that, and high-grade serous ovarian. It's the classical hereditary breast cancer. So in this patient, I would like to do on a different platform and a much larger panel, like a clinical exome or so. And it is important maybe for a treatment point of view, not but for the rest of the family, because the others, what advice will they give to them? Now my last case. Okay. So I'm saying that, I don't know whether it can be read or not, but so this lady, she is 42, healthy lady, again doctor, family full of doctors, okay, with history of breast cancer in her mother and sister, identified germline CDH1 mutation in the family. And for all you know, you may not have dealt with the CDH1 mutation, but panel mein to aa gaya. Okay. And she was tested, and she is also, so she's a healthy, anxious lady with a CDH1 mutation. Why I'm bringing up CDH1 is that earlier said CDH means you will get gastric cancer, have a prophylactic gastrectomy. Can you imagine? Getting someone's stomach removed. I mean, that is such a horrible, brutal thing to do, but people actually were getting their stomachs removed because they've seen so many people in their family die of stomach cancer, and it is all the most aggressive kind of stomach cancer you get into. So then that's where the importance of counseling in specialized centers. And it took me some time because they had all come red. They were scared. Now doctor bolega abhi stomach niकालो. कैसे निकालो? This 40-year-old lady को बोलो तुम्हारा stomach remove करो. So earlier studies reported a very high lifetime risk of adult onset cancers, primarily for gastric and breast cancer, and the risk was 80 to 90% for gastric cancers and 50 to 60%. The past and even current screening prevention recommendation for CDH mutation carriers, including NCC and all, are influenced by these very high risk estimates, which may be attributed to ascertainment bias of initial cohorts with strong families. So initially CDH1 was tested only in those who had a really very strong families. Okay. So based on that, so more recent studies show a lower risk of gastric cancer in a cohort of 238 carriers of CDH1 pathogenic variant. The stomach cancer, gastric cancer by age 80 was only 42%. Okay. And similarly in a population-based studies, they show that the stomach cancer risk was much less. So I think once based on this data, you can tell them, although it is part of standard guidelines. Next please. So about breast, of course, and prophylactic mastectomy, I have said utility in CDH1 carriers is not known for two reasons, because this cancer risk is not as I and it is lobular carcinoma, I also tell them that lobular carcinoma are more difficult to detect. On mammogram, you will have to only do basically on MRI, and MRI has its own mistake. And for stomach cancer, and this was a lot of discussion that you do all this EGD with duodenoscopy and CBC, fecal occult blood, blah, blah, blah. Then prophylactic total gastrectomy, she was explaining that earlier recommendation for this surgery are likely to be influenced by very high gastric. So this is an option, but telling them this is not. So that was very important. And of course, ovarian cancer risk is increased, but not so much that it warrants. And this is, I think I'll just finish. This is what we do after we find a mutation in a patient. We, depending on their age, whether they have cancer or not, and whether they have completed family, we give them advice. So this is risk management plan after the genetic testing, post-test counseling. We tell them what are the risks, and based on that, I'll just tell one aspect of this. So of course, option of prophylactic mastectomy, we say you go and talk to this thing. Many people think that they have to do it. This is an option. You don't have to do it. It's only an option.
If I may ask, like, given that the repercussions are so huge, and given that you yourself mentioned this was not one of those expectations, and given that it is an indent, it's a frame shift, how often would you want to, as a clinician, we want to kind of like validate it by Sanger's? That could be one quick experiment to.
So all the variants initially we have confirmed almost always the test sensitivity and specificity.
Even in the indels, I mean, for the mutations, I will kind of like be okay. In this case, it is indel.
No, not this one in general. This is just in general, advice for mutation carriers. So what is, I tell them about RRSO. So first of all, it can be done anywhere, but many times the cancer is the fibrin end of the fallopian tube. So there is a FIMS protocol so that they don't miss out early epithelial cancer, intraepithelial cancer, the fibrin end. So that thinner sections they do. And they still have a risk of primary peritoneal cancer. Sometimes they have the operation correct will be cancer over, so that risk remains small risk. Then about HRT. Earlier they used to say no, BRCA1, BRCA2 is one, but you just imagine a 35-year-old lady who has just take her source of estrogen, they really become miserable after that. So till the age of natural menopause, more recent data is suggesting till the age of natural menopause, especially if they are having distressing postmenopausal symptoms, we can give them HRT. Sometimes all they require HRT is just for 6 months or 1 year, and then they become popular. So the it's an operation is small. And Garvit, sometimes the breast surgeons, they underestimate the impact of removing ovary. 20 operation ovary bhi nikal denga. Arey aise mazak nahi.
This was quite direct, but
I'm just telling you. So like gynec, they understand what happens, and patients have sometimes they have so the mood swings and all. So this the husband also has to be counseled.
Yes.
Sir, there is a.
It is.
6 months to 1 year.
So we use tamoxifen, we use AIs. Both are giving equal amount of.
Surgical functions. Surgical menopause when it happens.
It is
Next day, sir.
I haven't changed my practice of telling the husband all the best once I'm starting something with tamoxifen.
No, that will happen gradually. The
Gradually.
husband will have time to acclimatize.
But yes, surgical intervention will.
By the time she finishes chemo, the husband is used to it.
So that is one thing. I think now, if they already had
how complicated this would get in your clinic if they are wanting to conceive, if they are wanting.
No, then we wait. No, if they want to have, they have only if they have completed family. If they have not completed family, or they may want to have a second child. Okay, so she has, like this lady, she has completed family and considering the risk, because screening for ovarian cancer is, might as well not do. It is unreliable. I tell them it is just give you a false reassurance that everything is fine. So I tell them it is useless. It's not entirely useless, but almost useless. And they have seen, anyone who has seen someone die of ovarian cancer in their family, they are very highly receptive. If they have not seen, then I tell them this is not like breast cancer, ovarian cancer. I mean, it's a horrible cancer.
Testing is.
Even after all these PARP inhibitors, it is still a bad cancer, isn't it? So, if they have already had ovarian cancer, now they want, sometimes BRCA1 mutation, you have a preventive mastectomy. I tell them only if it is well controlled for several years. Otherwise, I do not recommend them because there is a risk of recurrent ovarian cancer. I mean, there are a few cases, 8 years, 9 years ago, they were treated for ovarian cancer and they are, doing fine. So except for them, otherwise, not. And those who have unilateral breast cancer, then we bring it about that the prophylactic contralateral mastectomy. But if they already follow, then they have low threshold. Many times what is happening, we are picking up during their initial treatment, neoadjuvant chemotherapy, so then they are very happy. एक breast की surgery के time, दूसरा breast का prophylactic हो जाएगा. So they are the ones which are, benefit. You do such patients, get such patients?
We do get such patients who would want
sir,
to.
is there a recommendation to do bilateral surgery if you find that, say, one-sided unilateral TNBC with BRCA positive? Would you recommend that surgery for both the breast at the same setting?
In those cases, what we tell them, like we have said, the risk of contralateral breast cancer bilateral is about 30 to 50% at the same time. So we explain to them. So then it's a choice. Sometimes they do not, because that will entail reconstruction or something else, or this side. So because that will increase the cost and time and everything. So sometimes understanding the risk, they say, okay, we will be on screening.
So most of the time what we end up doing in the unit also is we will try and tell them what is the risk of recurrence because of the current disease that they have and what is the risk of a second primary which is there. At some point of time in follow-up, these risks will, obviously at the start, the risk of recurrence is much higher and risk of second primary is much lower. At some point of time, this graph is going to be reversed. When that happens, we offer them this thing. But yes, at the same time,
I agree what you say, but that is probably for a patient who's already been operated and then you find out that they are
but
BRCA
for a
positive.
ERPR positive OBC, one, it is very highly unlikely that you will have a patient with a BRCA report already done. Rest, she is already a carrier and she's been diagnosed with cancer. But for a TNBC, yes, I would insist on getting especially if it's an early breast cancer, do a BRCA one. We can have that discussion at a later point of time. At least if I don't have that report, I'm not going to be able to have that discussion. But yes, we do have that discussion of bilateral mastectomy.
So actually, many times what happens, they had a BCT earlier, and now they are on adjuvant treatment, and then the report comes BRCA. So in this case, if it was a early, suppose it was a T1N0 or T2N0, I tell them they have an option of completion mastectomy on the this side and contralateral preventive mastectomy. And if it is a T1N0, they won't even require radiotherapy. So they have a double advantage of avoiding radiotherapy. So in them, but it's another operation. So then they are mentally prepared, financially prepared, etc., and time all this.
Difficult calls. It's a difficult call to take for the patient as well.
About 30% patients run away when such discussions happen and they don't come back for treatment.
Sometimes you have to finish the primary treatment then.
Well, I think and then helping their families, that is, I think that is really satisfying, and they need advice, they need counseling. I mean, just imagine a patient, and kitne log aate, kitne log families wale bahut ho.
I had a dentist whom we picked up as BRCA2 positive. We had treated her. She was about 37 when we diagnosed her. Very aggressive disease. And then we screened the family. Father turned out to be a BRCA2 carrier and we detected prostate cancer in him on screening.
I think some very interesting cases you had. So with the time constraint.
Yeah, but these are consecutive.
And
then some are, for.
I think more cases will be more better with the outcome. I think you have the highest data. So I think we need, rather than this testing, interpretation more important. Just getting test is not important. As a clinician, what we need to answer the patient, right? So then, and different answer from different people doesn't make sense. Then we do send to you. So thank you, sir. Thank you for your time and good presentation. I think let's move to last presentation. I request Dr. Datta to have a quick presentation on it.
Sure. Do you still want to have a presentation?
We can have a quick view on that, yeah.
Or we can do it for the next round. I mean, the next meeting. Okay. So
you have been very patient for all of us.
I'll make a quick one in that case.
Sir, does any data on the overall survivor benefit with these prophylactic surgeries?
See, there is the breast cancer specific mortality is improved, so there is a Cochrane review for prophylactic mastectomy, but not overall survival.
Not overall survival, yeah.
But RRSO, yes.
RRSO does improve.
RRSO I strongly recommend.
There is one, this thing on BRCA2 with prophylactic mastectomy and overall survival also, but That's a very small difference which has been seen.
And chemo for BRCA2 carriers, I advise them tamoxifen chemo prevention.
Okay.
For how long, sir?
How long, sir? Yeah, that's
For
a
at
question.
least 5 years.
20 milligram? 20, 10.
Abhi to 20 kar rahe.
But there is
I
this new
understand
data
that.
which is
Yeah,
coming up
no
with
dose.
baby
Baby-
tam.
Baby tam.
Yeah, abhi, but till now.
And if I might quickly ask, like, how much, I mean, completely different from this, how much has this trastuzumab deruxtecan, the low HER2, how much it has really affected the clinical thing?
Maybe I very good answer.
Currently, it is not available in India. They are still thinking of launching it. The D-dish test and the sensitization of the entire oncology community is currently ongoing, looking at the new classification from the CAP with the HER2 low. And of course to look at the 1+, 2+, of course. But the data is very convincing, because it is being utilized even for the HER2 positive patients now, and even the HER2 negative or HER2 low category. It would come from 0 to 3. So it would probably come in as a first line metastatic therapy in about 2 to 3 years time. That is what we foresee.
But TDM is already here.
Yeah, but this is much better than TDM1. The direct head-to-head comparison showed that this was better than TDM1 in the HER2.
0, 33% response.
That's what I think, like, maybe
They're
the
thinking
game.
of launching in November.
Yeah, they are launching in November. Currently, they are taking surveys from
But like
multiple
6
people
lakhs or
as to what is
something?
this. Yeah, right now it costs about 10 lakhs for the each dose. But
Stomach is much more because the dose is 6.4.
Yes.
For breast is 5.4. That's the
10 lakhs we finish all surgeries, treatment, radiation. No? In 10 lakhs we finish all treatment.
so one
And we
dose.
have some
this is one
safe
dose. One dose, 3 weekly. Until disease progression.
Lifetime.
For HER2 and HER2 low is 5.4, but the stomach is 6.4.
financial toxicity.
Yeah. I think Dr. Amit will start.
No, they will bring out with some support program, I'm sure. But it's
You know,
still
the
going
most
to be
expensive drug, I have one of these meetings for motor neuron disease, 17 crores.
Yes.
Novartis की drug है.
Novartis.
It's a gene
It's a gene therapy.
based drug.
CAR-T? No, CAR-T is less than
नहीं नहीं
It's
Cardiac is
crores.
cheaper है.
CAR-Ts are cheaper.
उसने बोला कि अगर गवर्नमेंट अपना टैक्स हटा देगा
40
तो
lakhs
16 करोड़ हो जाएगा.
4.5 crores is coming.
हाँ.
For ALS.
I mean, I thought only oncology is बदनाम है, लेकिन वो तो 617, 60.
For ALS also.
हाँ. So it would a lot like that.
Gene therapy.
So, good evening everyone. So I'm going to make this a little bit quicker and I'm going to skip a few slides. That wasn't me. I'm basically not a clinician. I'm a basic scientist, and I'm also a not molecular pathologist or a molecular biologist. I mean, just a disclaimer. What we are going to talk about today, wanted to talk about the topic that has been given is that now doing this NGS testing and reading this report is more of a mundane affair. But there is much more to that. It is like far more complex, and that is behind the screen, and that's perhaps the reason why this topic has been chosen and has been given to me. So we're trying to see the nuances of this report, and as a clinician, when you are looking at the report, it's not just what is written out over there. There are some aspects of critical basis to it. Some of them Dr. Sareen has already alluded to. There is a huge plurality out over there. There are different labs, so you may want to know it upfront with regards to the accreditation of the centers from where it has been performed, and what kind of testing that has the center from which you're getting your report has already been done. So you may want to know from these reports that the genes and the regions covered. I mean, you as a clinician, when you're ordering for these tests, you may want to be very sure. Dr. Sareen gave a very good example where in his case, in one of the case where he was able to expand, or he was able to kind of like make his gene set of genes dynamic, he would change it. So it's very important to know that what exactly is the genes that what you are wanting to do it. For example, now what I call it as an evidence regression. So there is less and less of of complexities perhaps required for qualifying a marker or for qualifying something that has really gone. I mean, for example, for the ALK, just like the phase 2, the RET, that was primarily the case 2 reports, and the mice model that really led to its approval. Interact similarly, and the MEC1, it was primarily the in vitro data that has really led to. So this field is evolving, and so is like such set of like genes. You would need to know, I mean, these are primarily lung, that what I have kind of like emphasized upon over here. So, but before you're ordering for what set of genes, you need to be very sure of what you're getting into as the genes and the regions that you really want it to be covered. And by the regions, I mean, Dr. Sareen has already alluded to it, that as well. You would need to know copy number aspects to be covered as well. For example, the bigger the region, you would get to know the information such as loss of heterozygosity and other different information, which otherwise would not be very apparent in the test results that comes to you. You would want to know the types of mutation detectable that comes around from there, and along with the limit of detection. Most of these reports, what I kind of like see around when I sit onto the tumor board, they do not really, depending on the platform that they're using Thermo Fisher, they are using Illumina, or you name it, the limit of detection is not always very upfront described. Somewhere down into the pages it might be there, but that is something which is very important that you may want to know it upfront when you're trying to make sense out of the data. You may want to know many a times about the mutation status, whether it is, I'll come to that a little bit more into that, whether it is a somatic in nature or it is really germline in nature. There would be some insinuations from the report, from the somatic report itself, that you would get to know whether it is a somatic status or whether it is a germline. But then at times this would not, because usually when it is done into the clinics, you only sequence the tumor. You do not sequence the paired normal. That is never a practice. It is the FFP samples. And many a times, having a clarity and an awareness about it, whether it is a somatic status or the germline status, is something which is kind of like very important. Variant allele fraction, variant allele frequency is something which is like very critical that you would want to know. Essentially what it kind of like, in the easiest way, what it kind of like turns down to, it's the number of times that you tend to get to see the mutant allele, that is the variant allele, over the number of reads that what you get at that loci. So, and this has huge implications. So if you would imagine that there is a drive, and especially in the case of like VUS and all, Dr. Sareen has been alluding to, if there is a VUS or if there is a variant which has a much high variant allele fraction, what does that it really suggest? It suggests that that variant has been selected for, and that's why it has been enriched. So likelihood of it to be a driver event would be much higher than it to be a passenger event. At the same time, suggestive of whether it is a somatic in germline, that would also be kind of the information that is that can come out from the VAF. So VAF is something that you would always want to know. There is a KRAS mutation, but what exactly is the VAF of it? How relevant is? There is a resistance mutation which has come out, but what is the VAF of it is something that you would want to know, and you should be able to interpret right. So as what I said, depends on the genes and the regions. Today, you may want to know, I'm more alluding towards the comprehensive aspect to it, comprehensive genomic profiling, because I'm personally a great fan of it, and I personally believe that that is something the way to go and way to do it. Information such as the microsatellite instability or the total mutation burden would not be there ideally in majority. It all depends. And then I have also seen reports where people with a smaller gene set, they tend to twist and tweak it, and they tend to calculate the tumor mutation burden out of it. Those are faulty. It is not really going to be having that information, whether they're at least 1 MB or more of a genome size, that what you are kind of like have really covered in your panel. And besides all of these points, it's also the coverage or also the depth. So you would want to see, when you're getting a clinical report up in your hand, you would want to see it upfront. What is the depth of it? I mean, has the individual gene which has been covered, I would say at least 250x, ideally 500x and above. should be the depth of coverage for you to kind of like say it with a lot of confidence that what you are something that you're wanting to go further with. I would skip this. This is with regards to an AI-based cleanome platform for automated generation developed by Pratik Chandrani, one of my doctoral student who is now a scientist at Tata Memorial. So I would not talk about this. Basically, what I wanted to talk about the different aspects of this clinical report and how we can interpret it. But this I can leave it for some other time. What I want to emphasize in this short presentation is what you are wanting to opt for, and then knowing critically that what are the major limitations which are associated with it. For example, the false negative. Now, the false negative is something which is kind of like way too far more common than what we tend to think about when the report comes in your hand. The panels that what you are testing, you are only looking at the genes which has been tested, but then most of these panels, they are abbreviated panels, and the genes which were not covered, the mutations didn't come apparent to you. Besides this, most of the panels that what you are ordering for with regards to the point mutations, none of them, majority of them, unless you're doing a CGP, they would not have this information of copy number changes or the structural alterations. And it is very important to get this information with regards to the MSI and with regards to the genome-wide LOH, because now we know that these are very much something immune checkpoint blockades can be offered to these patients, which otherwise does not kind of like get really Another important aspect is the cellularity. You need to kind of like know, I mean, 30% cellularity is what something that you would really want. A pathologist might even kind of like, you may do a rigorous screening in-house. Your pathologist might say it is 30%, but then it may need not be. And then there is an attrition even at several other levels. So essentially you might be landing at much, and then the ramifications that are associated with the lower tumor cellularity is huge and immense. Perhaps I wanted to emphasize that upon today, but I would not go into the details of it. Just wanted to let you know with a red mark that cellularity of every report that comes across in your hand should be something that you should really emphasize upon. I just briefly mentioned earlier about the tumor mutation burden calculation. It's several times, there are enthusiast reports out over there that tend to give you a tumor mutation burden, but unless it has been dealt with, or unless there is whatever is the limitations required, minimum number of genes required, it may not be informative, and that may kind of like confound the findings that you would. I would skip again this. Basically, I wanted to show that why these kind of cellularity and the contents are important, because it may lead to copy number information. For example, what we are seeing, if blue is the LOH, if yellow is the LOH, you would see that anything that is going beyond blue is the LOH, then anything which is going beyond like 80%, 70%, 60% cellularity, it's kind of like totally lost. Now, you would not even kind of like know it up front, and for that you will have to read in between the lines, you will have to go dig deeper into it. Dr. Sareen has very elegantly already kind of like addressed about the VUS. You have all the different levels of evidence, which is already that most of these reports would be kind of like already emphasizing onto it. VUS is something that you really do, and more often than not, you don't know how exactly to kind of like address these VUS when it is kind of like occurring. Allele fraction is something that what people tend to kind of like relate it onto, but that has its own limitations to it. Besides the variant of unknown significance, what makes the things more complicated are that when is a mutation which is known to be a driver mutation becomes druggable, or for that matter, when does it become even relevant? You would know there are several other factors. For example, the diagnosis at the right stage. And a good example that I can kind of like cite you over here is that most of the solid cancer cases that what you're doing, which is like stage 4, they are akin to the blast phase of the CML. Now, if you're finding BCR-able at the blast phase, then that's not druggable, even though it is a driver alteration. So similarly, not all the alterations that what you're finding in your panel would immediately be druggable. There is something much more to that. There is also a cooperative milieu that what I kind of like call about. So for example, you find these kind of like alterations in ARID1A, PIK3CA, they are known to exist in endometriosis, but they do not lead to any kind of like transformations, and these are classical oncogenes. Now these classical oncogenes occurring in endometriosis, these classical oncogenes coming into your samples, what exactly to sense to make out of it? Similarly, P53 in synovium of like, it is found in rheumatoid arthritis. Now these are guardians of the human genome, and you're finding to be like so significantly mutated nevi, something which is kind of like we know that they're not getting transformed to melanoma, but 80% of those nevi are positive for the BRAF 600 mutation. So you would see that the levels of complications are way too far more, not just into the VUS, but also into the known activating mutations. And that's what I kind of like call it as a cooperative milieu. It is the context which is kind of like is important, and that is again something incumbent on the clinicians who are actually watching, who are actually having these reports in their hand and trying to make sense out of it so that you could decide a therapeutic regimen onto it. Similarly, the ORB2 overexpression and amplification, you tend to get to see across. And in fact, in DCIS, it is way too more than compared to, I mean, this is really paradoxical, that then you would see that in the breast cancer, in the invasive aspects of breast cancer. Similarly, the BRAF mutation in hairy leukemia and melanoma, they have a different connotation. And so understanding the concept, the context is very important, not just what is like written out there onto the report that comes. So that's which has already been kind of like discussed over here. The molecular tumor board, where you have people from expertise from different and diverse and plural background need to put their head together, and that's something that is kind of like really important. So what is also incumbent, because we are looking on to only the somatic aspect to it, but what is also incumbent that the clinician is expected that you cannot just stop over there. You would have to kind of like cater your patients and tell them that the likelihood of the germline from the somatic report, Dr. Sareen has already in deep detail elaborated onto it. So when would you do that? So there are ways of doing. I mean, people would say. I mean, this is again a misnomer. We tend to get to see many a times. I tend to get to see in the molecular tumor board that if the VAF is beyond 50%, then it is most likely going to be associated with the germline. It's not always the case to be. It is several other aspects that are associated, the cellularity of it, and then there are situations where there could be multiple LOH events across the whole genome, and that may kind of like may bring the VAF significantly lower than 50%, and still it might be a germline. So there is nothing kind of like holy standard to kind of like define when it's going to be a germline, despite the fact that it is the clinician is expected to kind of like advise their patients for the likelihood of it. So something that I always kind of like emphasize upon into the molecular tumor board is to the strong family history. Dr. Sareen has given the right proof and the settings for that to be. And secondly, the genes which are known to be involved in MSI and others, if they tend to be altered at a certain frequency, certain VAFs, then the likelihood of these patients to be validated by an orthologous technology and then advising for the germline testing is something that I wanted to talk about the false positive aspect as well, and primarily into the ctDNA, because this is something that, am I still left with night time? Maybe in 2 minutes, 3 minutes, perhaps I will. Yes. Okay. So, ctDNA, I mean, you cannot have today's report by just talking about the tissue biopsy. You have to talk about that what is expected and how to interpret from a report of a ctDNA in the liquid biopsy. So, something which is kind of like very important and paramount is to know about the ctDNA fraction, which is the amount of DNA which is coming out from the tumor cells and the amount of DNA that is coming out from the say WBCs, the white blood cells, because the DNA which is coming out from the white blood cells into the blood, that is forming the cfDNA, that is the cell-free DNA, and the one which is coming out from the tumor is the ctDNA. How do you make a distinction between them? You can make distinction between them only by performing the sequencing. Now, here is a study where, and this is more often than not, but I do not get to see most of the QCs being done. People tend to kind of like order for ctDNA day in and day out the moment they kind of like see an opportunity to do so. But actually, ctDNA is higher in certain cases when it is a metastatic settings, or whether it is kind of like horizontal or longitudinal monitoring that is required to be done. In this study, and this is kind of like well established, of 201 patients, 40% of them, they did not have a detectable ctDNA. So ctDNA are more likely to be negative if it is done for majority of the patients and without, and the ctDNA ranges are also kind of like very weird. The fraction of the ctDNA could range from 1 to 90% as what you could see. We can talk more about it like some other time, but why is this fraction important? The ctDNA fraction, most of the reports do not talk about it. They simply talk about liquid biopsy kiya hai, and after doing liquid biopsy, these are the mutations which is kind of like positive. But no, what really happens around over there is that if the ctDNA fraction is not mentioned, there would be huge amount of alterations. For example, the biallelic deletions and all, that requires at least 30% of the ctDNA fraction. If you were in this range, and you were in the range where it is when it is a lymph node metastasis, for example, or the ctDNA content, the fraction would be near to 0. And in that case, you may not really find anything and you may call it as a negative result. Now, that's kind of like a false thing. And similarly, in the metastatic setting, it all depends where you are. Pardon me, I'm going like pretty fast in here. I wanted to emphasize that, especially with regards to the BRCA2, BRCA1, ATM1, copy number alterations, it has been shown that ctDNA, again, depending on the CT fraction, is very significantly affected. I mean, that's based on the PROfound study. I wish we could have elaborated and I could have detailed it around. Just one is that wanted to show is that copy number loss, when the ctDNA fraction below 48% was not there, it was found to be like that it would not detect. And BRCA2 or BRCA1 alteration, if you're missing out in the ctDNA, which will happen more often than not, you are just depriving the patient of the olaparib. So, and you are going with a much more sophisticated way of determining it by doing a ctDNA. So knowing about these limitations is something which is, and the false positives that is in this liquid biopsy, that is way too far more often. You are so well more knowing about it, about the chip. Because of this, there are several of DNA repair genes. What they tend to come out as a false positive. Incidentally, like genes such as p53 and all, which is common between the chip and into the hematopoiesis, clonal hematopoiesis, and in the cancer. However, the clonal hematopoiesis may have nothing to do with it, and you may want to kind of like go ahead and, for example, here it was found that at least in this study, that 10% of the repair gene, now these patients would have otherwise received olaparib, but actually this was a false positive due to the chip. And that was just the clonal hematopoiesis. Like, so I would skip this. So basically what we have kind of like talked about, we talked about the false negatives associated with the tissue biopsy, and the false positive associated with the tissue, with the liquid biopsy, and a little bit of some details of the stringencies that one need to know upfront before one is ordering the test, one is placing an order, and one is wanting to trying to make sense out of it to pass it on to the patients. Happy to detail it some other day, because this is something which is kind of more of like discussion based, and more it should happen in an iterative manner. But should there be some question and there be some time left, I would be happy to kind of like take it up and discuss this further. Thank you.
Thank you, Dr. That it was a really interesting presentation. With the lack of time, I think we'll have a question or maybe dinner. And if anyone have questions? If no question, then we may close the session then. And I'll ask Tanya to proceed for further.
Yes, I would just like to invite our founder director, Mr. Shubhamay Dasidar is here. So before we break for the dinner, and if we can, and make
Yeah, good evening, doctors. I'm very thankful that you were able to make it and share your expertise, skills, and there are many participants who are there who have been learning from you. OncoPrecise is something new which we have recently introduced in the market. We expect that it should provide some kind of a benefit for the patients, and of course with your feedback, with your guidance, with your because what we want is that our clear, I think we have discussed with Rajesh and Tania and the team also, that going forward we would like to make it more better price point for the patient, more tat friendly for the patient. But the product is new in the market. We want your feedback, your support, and with that we can expand, and with that we can further pass it on the benefit to the patient. So with that, I would, sir, you have.
I think we have discussed everything. So with the pricing, I think with eventually the time it will goes down, right? This is then we have been witness to the lot of tests happening. More we use, more we come, and then we come to some reasonable pricing also.
Correct. Definitely.
Yes, I think we are done with today's program. Thank you, everyone. It was really a short period inviting you all and confirming the time and getting you all together. One of the lot got stuck at sunrise opening at Chembur and could not really come up. We are really apologetic for that. But a lot of things even I also wanted to discuss. But Prosigna is something which is in the category we are trying to build up, and our endeavor and objective is maximum number of patients should be able to utilize it even with the Indian economical setting. So when we have asked each and every doctor, whether it's surgical oncologist or medical oncologist, I do understand whenever there is a prognostic tool coming in, whether no chemo or chemo, rather I would also put it across that there are cases where patient does need chemo and online predictor says no, it is not needed. So we are also missing out on that. So our endeavor has been earlier because it was shipped outside, it was around 2.5 lakhs. We have got it down for the institutional pricing at 1,10,000 and any walk-in patient coming in at 75,000. So that maximum number can reach, and the least TAT that we have reported, that is last week, 7 reports has gone out at the 4th day reporting. So that's been our endeavor, and we are still trying to bring it to the best. So thank you, everyone.
Thank you.
So the dinner is outside, so we invite all of you to come for the